Welcome to AETCM, the emergency medicine channel. Today I'll be presenting a case of a 60-year-old female who presented to ER with complaints of fever, myalgia, headache, vomiting and bleeding from gums. On initial 10-second assessment, patient is conscious, oriented, obeying commands. Primary survey, airway was patent, no gurgling sounds was tried up, breathing, air entry bilaterally equal, no added sound, saturation of 100% on room air, respiratory rate of 20 per minute, circulation pulse rate of 62 per minute, BP of 189/100 millimeters of mercury. Capillary refilling time of 2 seconds. Disability, GCS was E4, V5, M6 and pupils are equal and reacting to light, moving all 4 limbs. GRBS of 122 and exposure-wise temperature was 97 degree Fahrenheit. Adjuncts of primary survey, ECG was taken showing normal sinus rhythm and VBG, no acid-base imbalance.
Okay.
Secondary survey, 60-year-old female, known case of hypertension, dyslipidemia, hypothyroidism. Presented with complaints of fever with chills, intermittent, associated with myalgia, arthralgia, bilateral frontal headache, anorexia. She also had multiple episodes of persistent vomiting, not blood or bile stain, associated abdominal bloating.
Okay.
History of gum bleeding was there 1 day back, and there is no other any history of hematuria, GI bleed, giddiness, syncope, abdominal pain, altered sensorium or behavior.
Okay.
She was admitted in outside hospital and was found to have low platelets. Further investigated to found that she was dengue NS1 antigen positive, and due to worsening of platelet count, she was referred to our center. Patient no known any allergies to any medications. Medications she took was Tylenol 125 microgram and Telma 40 mg and atorvastatin 10 mg. Past history of hypertension, dyslipidemia, hypothyroidism. And on examination, a patient was conscious, oriented, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. CNS wise patient GCS was 15 or 15.
Anything positive that you
no positive findings.
Okay. So basically we have 50.
Patient 60-year-old.
60-year-old lady who had a previous history of fever 1 week back.
Yeah.
Now she has got bleeding gums, low platelet count.
Outside dengue.
And outside dengue was positive. So it's basically a dengue fever patient with low platelet count. It's a classical presentation that we have got. So as our primary, you have to stabilize the airway, breathing, circulation. So we have done that. But here the platelet count was 15,000. Most importantly, she had bleeding gums. So that is the reason. So when will you transfuse platelet in dengue fever?
Ideally, if it is below 10,000, only we should transfuse. Otherwise, there should be any active bleeding as such should be present for prophylactic transfusion.
Okay. Or you are planning for any elective procedures. You wanted to have 50,000 brain surgery, more than 1 lakh. So these are the usual threshold that we wanted to look in for. But here, whatever be the platelet count, she had an active bleeding. So that's the reason why we went ahead with the transfusion of what transfusion was done.
We have done random donor platelet transfusion.
Okay.
RDP,
How many? 4 RDPs. 4
RDPs.
4 RDPs transfusion was done. And 4 RDP is equivalent to half SDP. So that is the usual. So 6 to 8 RDP is equal to 1 SDP. SDP means single donor platelet. So you are taking it from multiple patients and pooling it together and giving to the patient. So that is random donor platelets. So you have done the transfusion. And what happened to the platelet count?
Then it initially improved to 40,000. Then again it fell back to 33,000. Now patient is having 31,000.
Okay. So what else you wanted to look in for a patient that is coming with dengue?
We have to initially see for the warning signs.
Okay. Dengue warning signs. I am telling of the complications.
Patient can have further shock episode.
Okay.
Dengue shock syndrome can occur, or any hemorrhagic episodes can occur. Organ involvement can be there.
So organ involvement, you can have simple organ involvement like transaminitis.
Transaminitis more than 1,000 and all is severe. Or any CNS involvement, altered consciousness.
You can have dengue encephalitis.
Then we
myocarditis. Okay.
Then any hemophagocytic lymphohistiocytosis.
That is what most important. HLH is one thing that we are seeing a lot of HLH because number of dengue cases is that much huge. So those who are coming into a tertiary care center, maybe every other 10 to 20 patients, we are seeing one patient with HLH as a potential complication. So when will you suspect HLH?
We have to, we usually send ferritin for most of the
See,
dengue
first of the
patients,
thing,
and
if it is a secondary dengue, that is the first thing. When it is a secondary, already they had a previous history of dengue. Now it's the second time. So the potency to develop HLH and severe dengue is more common. So that is a one thing. So again, we cannot predict which patient is going for an HLH. We cannot say. Maybe a young, healthy adult can go for an HLH. Maybe an elderly patient can go for HLH. But as a baseline routine, it is always better to do what, from our experience, what we had seen, whenever there is a dip of platelet count more than less than 50,000, it is always desirable to think that the patient can go into a potential complication. And another thing that when you can suspect is a rapid drop of platelet count. Usually we'll have like 15 to 20,000 drops usually per day. So the usual trend will be the fever will be there initially to start off with. The fever will subside like 2 to 3 days after the infection. Then the later on, the slowly like 5th and 6th day, they will start noticing the platelet drop. And by 10 days, the platelet drop will be there. And by 11th, 12th day, the platelet will be coming back to normal. So that's the usual trend. Usually when you look into this normal patient, like 10,000, 20,000 will be the maximum dip that you can anticipate. 10,000, again, maybe depending upon the viral load and host factors, that is the factors of the patient, that because patient taking antiplatelets and all, maybe the dip will be much more faster. But whenever you suspect rapidly, 1 lakh was the platelet, now it has come to 50,000. Suddenly, OTPT, organ dysfunction, the patient has become more and more toxic looking. Then you have to suspect probably HLH as a potential complication that is happening. And then you have to look in for the ferritin level, very high ferritin levels, and triglyceride levels, fibrinogen levels, low fibrinogen level. These are all suggestive of that the patient is going for HLH, where the high dose pulse steroids is the treatment of choice. So that is the separate entity. But what was the ferritin of her?
Ferritin was 3,000.
So 3,000, it's not normal, it's definitely on the higher side. But when you have a patient with HLH, we usually see about 10,000, 15,000 and all those ranges. So we are not suspecting an HLH, but she had a dengue fever with bleeding. So that's why we have transfused her. So can continue what happened to the patient.
Okay, after that, next day she was having mild agitation. She was complaining of generalized weakness, and she was complaining of pain, headache, and arm, upper limb and lower limb pains. And after that, BP was, we had started Telma, was she was taking 40 mg HS was she was taking, but BP was uncontrolled the first day of admit. So we had added amlodipine 5 mg morning we had added, and again we had monitored BP, but towards night she was having worsening of this discomfort, and next day morning she was having acute onset blurring of vision, and she was not able to see any of us. So further we had suspected because the BP was persistently high, and she was also having this agitation and confusion with this blurring of vision. We had suspected posterior reversible encephalopathy syndrome initially, and we had started for so it becomes a hypertensive emergency as such, and we had started for BP control initially with we had started NTG, nitroglycerin was started, 5 microgram per minute, lowest dose we had started, and we had brought BP under control, and we had planned for MRI brain plane. So before the MRI itself, patient had one episode of GTCS, lasted for around 1 minute, and only settled with midazolam injection. And then we had taken the patient for MRI brain plane, and it was showing cortical and subcortical white matter T2 flare hyperintensities involving the supratentorial parenchyma, mostly in the bilateral parieto-occipital region mostly, and less in the right frontal and temporal minimal. And also there was also so they had said it as similar present. It has suspecting PRES itself, features of PRES itself. So further we had again went ahead with the management of BP control, and our initial target was in the first 1 hour we had targeted less than 25% reduction in BP, and then further we had planned to keep it below 140/80. We had planned to keep. And but the patient was getting patient was getting agitated and was complaining of discomfort, and she also hasn't had sleep in last 4 days also. So we had planned for sedation for the patient, and ideal agent we took was dexmedetomidine, and dexmedetomidine we started at initially bolus was not given so as to not drop the BP so much because it can cause ischemia. So first we had started her on infusion, 0.2 to 1 microgram per kg per hour. So we had initially without dilution, we had started with 1.2 ml per hour, and we had titrated according to response. And we had kept the BP around 130, 140. We had
Systolic.
kept systolic BP, and 80 we had kept diastolic.
Okay. So let's see one of the commonest in the ICU. So what we had seen is that classically you will see this in pre-eclampsia, eclampsia, autoimmune disorder, and sepsis also you can see. She's having a dengue sepsis. So that's one of the trigger that we had seen. And what our experience that I have had, we had seen patient post-transfusion, post-blood transfusion, PRBC transfusions. Because of sudden volume increase also, I had seen few cases of patient going to posterior reversible encephalopathy syndrome. So what is the basic pathophysiology behind this?
Pathophysiology is mainly the autoregulatory failure, which happens because
so
of
there
the
are, when you look into the definitive pathophysiology, different books say different things. So there are one, as you said, autoregulation, cerebral autoregulation failure. So that is a one reason, and resulting in vasogenic edema, and resulting in posteriorly, that is the occipital region. That is the reason why the patient is complaining of blindness. When you look at the optic pathway, when you look into the eyeballs from there to the tract from the optic chiasma, then the crossing over of the fiber, nasal fiber, then finally it is merging into the optic region, so into the occipital region. So that is the reason why you won't get a classical scotoma sort of a picture. The patient will be having some blurring. I am unable to see these things clearly because of that vasogenic edema, which is most happily in the occipital region. So that is one of the pathophysiology. And other pathophysiology means endothelial damage. That is the another different one of the another pathophysiology. And there is one more. I think there is vasoconstriction. There is another vasoconstrictive theory also. Cerebral ischemia causing vasoconstriction. So these are the three possible theories that has been found out for the reason behind posterior reversible encephalopathy syndrome. The most important thing, the patient will be sudden onset. So we'll think that whether it is a stroke, because sudden onset of blurring of vision, altered sensorium. So it is, I am not saying it is not stroke, it is something similar to stroke, because there is a transient ischemia to the brain. But once you control the blood pressure and once the edema settles, within next 48 to 72 hours, the vision will be back and the patient will be quite normal. So the only thing what we need to do during that time is to settle the blood pressure under control, keep it under control. Maybe nitroglycerin or oral antihypertensive you can escalate. Labetalol is also an excellent option. Initially, we didn't choose labetalol because of the heart rate was not very high for this patient. Heart rate was around 60 to 70. So in terms of dengue with possible myocarditis, we don't want to give a beta blocker so that the heart rate further drops. So nitroglycerin we have started. It's a reasonable drug. If you look at the first line of agent will be labetalol, then followed by hydralazine IV. If it is available, that is the best option. Previously, it was available. These days, not available. So the next option what we have is NTG infusion. So you can start on NTG infusion and target a lower blood pressure. And most important thing is that you need to suspect this. So when will you suspect this? Whenever the patient BP is getting uncontrolled, slowly the patient start complaining of headache, and visual disturbance is already the PRES developed. So when the visual disturbance has happened, it will already, the patient has gone into PRES. So you need to anticipate this, and you need to have adequate sleep deprivation was one of the trigger for this patient. So even if we were giving her good doses of benzodiazepine, still on top of that she was not having an adequate sleep. And when we examined, she had grade 4 hypertensive retinopathy and papilledema and all. So that was the reason her BP was uncontrolled for a quite long time. So that is the reason why this has suddenly exaggerated. Maybe steroid as a per se, when you look into the steroid as a per se, as a treatment option, it can some amount decrease the vasogenic edema, but it can also cause volume overload also. So water retention, sodium and water retention, and can also increase the blood pressure. And we have given some blood transfusion also. We are not given like 2 or 3 pints of bloods or something. We are given few RDPs. So again, she is in sepsis. So it's a multifactorial things. Already hypertension, under uncontrolled hypertension, and giving steroids, sepsis, all these things together would have triggered a posterior reversible encephalopathy syndrome. So this is very common in postpartum patients. So postpartum, pre-eclampsia, eclampsia and all patients who was receiving magnesium sulfate and all, and have delivered. Postpartum, they will complain of blindness and all. But once you treat, the patient will have dramatic recovery. So the patients will be very happy. So that is the advantage. It is automatically, it's a posterior reversible encephalopathy syndrome. We just need to control the blood pressure, and you can give vasogenic edema decreasing treatment. We can maybe 3% mannitol, but again, hypertension is there, then 3% mannitol, 3% whether you want to give it again. There are a lot of controversy. Definitely, there is no much role for your steroids, but we can argue it can decrease vasogenic edema. So that is the only treatment per se as such that what we wanted to know. But in ICU, this can happen very rapidly. The patient can deteriorate, and visual loss. Whenever the patient is complaining of sudden visual loss, headache and agitation, always keep in your mind that there is an entity called as posterior reversible encephalopathy syndrome. Even if described in preeclampsia and eclampsia, it is very common in other, because we have seen equally in both groups of patients, not in just in pregnant ladies, preeclampsia, eclampsia group. We have seen in adult patients who is having chronic hypertension, uncontrolled hypertension. Okay. Anything else that you wanted to add on, depending on PRES?
The risk factors we had discussed, the hypertensive decision, which either very high BP or acute fluctuations in BP, or it can be seen in renal diseases also, acute or chronic renal diseases, then autoimmune conditions, then thrombotic thrombocytopenia purpura, HUS, eclampsias, as we said, then vasculitis conditions also, SLE, polyarteritis nodosa, granulomatosis polyangiitis, and then immunosuppressive drugs also can cause. Immunosuppressive drugs are chemotherapeutic drugs, as in bevacizumab, cisplatin, most commonly seen in cyclosporin.
OCPs, they have found out anything? OCP,
not mentioned.
OCP as such, they are more risk factor for developing venous embolisms. OCPs, the patients on OCP. The closest differential diagnosis that you need to attribute maybe an acute stroke versus a cerebral venous thrombosis. So an MRI with MRV will be an ideal option for this group of patients. Because again, vasculitis, everything is a risk factor for your CVT also. Pregnancy is again a risk factor for CVT. And they can have multiple cranial nerve palsies also, depending upon where exactly is the edema is.
And other causes, as we said, sepsis, then other electrolyte disturbances can also cause hypercalcemia, hypomagnesemia. Then usually the thing which is seen in so this thing, it is that it is more involved in the white matter than in the gray matter, because the edema, it does not involve much of the cortex because it's tightly packed. So it more seen in the white matter and more in the posterior part, because the adrenergic nerves around the pile and the intracerebral vessels, they are reduced in that posterior area and more in the anterior area. So anterior area, they'll have more of that autoregulation
mechanism will work.
So that's why it's mostly seen in the occipital, mostly in the parieto-occipital regions.
Classical MRI finding also you can just describe.
MRI findings, usually what we see is a hyperintensity, which is seen in T2 as well as T2 flare. It's best seen in T2 flare. It involves the posterior cerebral part with sparing of the calcarine and the paramedian portions, which is usually involved only in infarction, stroke as such. And in CT brain counterpart, we'll get hypodensity in that similar region. And the sparing of the cortical gray matter is also typical for this one. Apart from that, if there is other DDs, you have to suspect, as we said, eclampsia can also, it can be interchangeable. Eclampsia as well as reversible process, it can be interchangeable. And also we have to suspect reversible cerebral vasoconstriction syndrome. That is mostly similar presentation, it is sudden onset headache. But these patients with vascular imaging will be able to see arterial constriction.
Vasospasm.
Yeah, more chances for constriction, vasospasm will be there with the RCBS. And there will be MRI findings of ischemia more than that of in RCVP. And also the differentiating factor we can in MRI, which adds on to the diagnosis, is the DWA and the ADC sequences. So DWA, it will be either isointense, hypointense, or sometimes hyperintense because of the T2 hyperintense. But the typical one which differentiates is the ADC one. ADC, yeah, usually it is hypotension in stroke, but here it will be hypertension.
So more of vasogenic edema that what we are seeing in the images.
Vasogenic edema is what is. And other, it can also mimic bilateral PCA infarction also, but in that there will be oculomotor pupillary involvement. Then CNS vasculitis, multifocal embolic infarcts, infectious neoplastic autoimmune encephalitis also we have to suspect. So in the fever and all is there, then we will have to suspect encephalitis, do LP, and further we have to see. And cerebral venous thrombosis, as we discussed. Also, the acute demyelinating encephalomyelitis was mentioned.
Dengue again, they can precipitate some autoimmune pathologies. Demyelinating disorders can happen, and dengue itself can cause encephalitis, like what we discussed. But the problem here is that the visual disturbances is very classical of this posterior reversible encephalopathy syndrome.
Visual disturbance.
Okay, fine. Thank you.
Right.